to the thorax. Move caudally, we move little caudally. As we go caudally, after the 3-vessel trachea view, we get the transverse section of the abdomen. Then again, we slide little more downwards, we get the chord insertion plane. That is from the 3VT view to AC view and then the chord insertion view. So what are the requirements in this plane? That is at the transverse section of the abdomen with stomach and umbilical vein, we see the situs. The situs is a very important thing which has to be evaluated. We take the AC, we take the abdominal circumference section. And if the AC is outside the normal range, it needs to be referred. What all abnormalities can be picked up? We see the abnormal situs. We see the stomach. The stomach is small or absent stomach. This is the duodenal atresia, ascites, and skin edema. And at the chord insertion plane, what do we rule out? We rule out omphalocele and gastrochesis. So what all things has to be seen in these planes? So first of all, stomach. We see the AC, if we see the abdomen, means first our eye should be on the stomach. The whole thing revolves around the stomach. First of all, we see whether the stomach is there or not, stomach is present or not. And if the stomach is present, whether it is a normal position or not. How will we know whether it is a normal position? We establish the situs. I will in later slides, I'll be telling you how to see the situs of the baby. Then we see whether the bowels are dilated or not, both the kidneys are present or not, and we look at the chord insertion site to rule out abdominal wall defects. So this is a transverse sweep. You see, this is a pelvis plane. I'll just repeat once again. So this one, this is the AC plane. This is from the thorax. I go caudally. I get the AC. This is the abdominal circumference. This is the umbilical vein. I go a little more downwards. I go at the chord insertion site. This is the chord insertion. Little more down, I get the bladder. That is a pelvis. I reach the pelvis. So this is a pictorial representation in plane 11, just below the diaphragm. You see the stomach and the intrahepatic umbilical vein. And then when we go a little more down, that is a chord insertion site, that we look at the abdominal wall defects. So it's just a repetition. That is we see the transverse section of the abdomen, we see the umbilical vein, we see the stomach bubble, and kidneys should not be visible. They should we are not supposed to see kidney in this plane. Slide, how do we go? Let this slide inferiorly from AC to sacrum, and the chord inserts superior to the bladder, as we already saw in this video clip. So what are the structures to be seen in the AC plane? The first and foremost important structure, stomach. I have to see whether the stomach is present or not. Second, the umbilical vein, the intrahepatic umbilical vein. This should be a C-shaped curvature. It should neither be too long nor it should extend to the chord insertion. Only this much segment should be seen. If it has to be a perfect AC plane, only this much segment has to be seen. It should not go up to the chord insertion. Then spine, we have to see the spine. The spine, the 3 dotted structures are seen or not. Single rib. This rib on one side, it should be a single rib. It should not be multiple ribs. It should not be an oblique section. It has to be a perfect transverse plane. Then again, the single rib on the other side, single rib. This is the liver. And here is the aorta. Just in front of the aorta, just in front of the spine, you find the aorta. Aorta is like hugs the spine. It is closer to the spine. And just to the right and anterior of aorta, we find the IVC. Why is this too important? The aorta and IVC is important to rule out isomerism, be it right atrial isomerism or left atrial isomerism. So these are the so many important things we have to see in a AC plane. First is the stomach, then the umbilical vein, and the single rib should be seen on either side, liver, aorta, and IVC. So initial years of learning ultrasound, when we start taking biometry, these are the common problems we face. These kind of images, at least I used to get when I started taking biometry. So is this a correct AC plane? I'm finding multiple ribs. I see only a faint stomach shadow. It's not, it's more of oblique. Is this a correct plane? No, this is a wrong plane. So what about this? Here I'm getting a good stomach. Here a small umbilical vein is seen. But is this a single rib? No, this is multiple rib. I get a single rib over here, but I don't get it here. So this is a wrong plane. This is not a correct AC plane. So what about this? This is again an oblique plane. I don't get a good spine. It's not a circular structure. I don't see the umbilical vein. So this is again a wrong AC plane. So what about this? This is actually a circular structure. I see a good stomach also. I see a small umbilical vein, but the problem is I see a kidney over here. So this is again a wrong plane. Kidneys should not be visualized in the AC plane. So it's not a perfect AC plane when the kidneys are visualized. So how do we do? We take it as circular as possible. How do we? It comes with practice, and we keep on rotating and sliding. We get a good circular structure. Then short length of the umbilical vein at the level of portal sinus. Just by rotating movements, we can get a short length of the umbilical vein. The stomach bubble should be visualized and the kidneys should not be visible. So how do we calculate? There are two methods. Either it can be an ellipse caliper method or the linear measurements. And how do we see? We measure from the outer surface of the skin line. We take it from the skin. We don't take it from the bone. We take it from the skin, from one end to the other end of the skin. Again, from the one end to the other end of the skin. So ellipse method, whatever is there in the machine, we can use that. It can be either ellipse caliper method or linear measurements. What is this linear measurements? That is, one is an AP diameter. AP diameter means from one end of the spine to the other end of the spine, and the other transverse diameter, that is just 90 degree to the first plane. We take the transverse diameter, and again the machine automatically will calculate the AC. This is how we get a perfect AC and hence a perfect weight. Now, without involving the first trimester pictures, I think the presentation will be quite incomplete, because the stomach bubble, as it is important in the second trimester, it is also in the same way, it's also important in the first trimester. So this is the first trimester stomach. This has to be seen in the first trimester. Stomach bubble should be visible in the first trimester. Suppose I don't find a stomach bubble here. There is no stomach bubble in the first trimester scan. So what do? I start searching for the stomach bubble. Where is it? Why is it not present? Or it may be transient empty, but why is it not present? But my focus, I should start searching. Where is it? So the absence of stomach bubble here. I search for the stomach bubble in the thorax. What do I find? I find the stomach bubble is sitting next to the heart. It is in the thorax. It is sitting next to the heart. So stomach bubble is inside the thorax. So what should be my diagnosis? My diagnosis is congenital diaphragmatic hernia. So such a complex anomaly can also be detected in the first trimester, provided we take the AC plane in the first trimester. So visualization of stomach in the first trimester is as important as it is in the second trimester. We rule out such complex diagnosis by seeing the stomach in the first trimester. Now come to plane 12, it's a chord insertion side. We again take a transverse view of the abdomen. The spine should be seen. This is the chord insertion. Chord insertion means you have to see both the intra-abdominal and the extra-abdominal. This view should be seen when we look at the chord insertion. Both the intra-abdominal, these lines should be seen, and the extra-abdominal. So this is a chord insertion at the abdominal wall. It is just above the bladder. If you go a little more caudally down, you will find the urinary bladder. So this comes out of an intact abdominal wall. So it is always better to put color in case of chord insertion, because why? Because abdominal wall defects becomes very obvious, but when there are small cysts like umbilical cord cysts, they won't pick up color. So it is always a good practice to put color Doppler while seeing the chord insertion. Then similarly, again, I'm highlighting the importance of the first trimester. The first trimester, when we do a first trimester scan, this image we are supposed to take in the first trimester scan so as to rule out abdominal wall defects. So if there's a normal cord insertion, no abdominal wall defect. The same as we do it in the second trimester. Now come to situs. Like establishing the situs is very important when we do a mid-trimester anomaly scan. Like there are many methods of establishing the situs. First is the, in many cases, we imagine ourselves as a fetus and establish the laterality. Some use a doll method, and I think the most convenient method is a right hand thumb rule. So I will be explaining the right hand thumb rule for trans-abdominal scanning. This is for the people who scanners who do scanning with the right hand. So again, I'll come back to this slide. What do we do? How to establish the situs of the baby? So by convention, this mark, all of us must be knowing about this mark. This is the probe marker of the ultrasound machine. By convention, in transabdominal scanning, this marker is always present in the maternal right side. This is this marker. This marker is always present on the maternal right side. So in the right, I think everyone has to see how the right hand thumb rule applies. So I have to, this is a right hand thumb. So what do I do? The patient is lying on the right side. The patient is lying on the couch next to me. So if this is a cephalic presentation, my hand, I will be keeping it, I think this one. So my hand, I will be keeping like this. So I'll make a fist. I think it's going other way. I'll make a fist, and this knuckles, this is the knuckles. The knuckles will be the head. This is the spine. This is the anterior abdomen, and this is the left. This is the left of the fetus. I repeat, this is the head. This is the head. This is the spine. This is the anterior abdomen. This is the left. So if it is a cephalic presentation, like the patient is lying on the couch next to me on the right side, my head will be down like this in cephalic presentation. So if it is down, means again my head is here, like the baby is here next to me. Baby is here next to me on the cephalic presentation. My head is here, spine is here. This is the anterior abdomen, and this is the left. So if we see this image, like which is I'm sharing now. So this is the maternal right. And where is the spine? The spine is, I will turn my, this actually my picture is rotated the other way actually. So if I think everyone can practice it. So if I turn it this side, my spine is on this side. My spine is on this side, and this is the left. So where is the left? The left is on the top. Left is on the top of the screen. So where do I find the stomach? I find the stomach on the left. So this is the normal situs. I again repeat, this is cephalic presentation. This is the head, spine. I rotate the spine. In the image, you see, in the image, it is on the maternal right side. The spine is on the maternal right. So I rotate it like this. I rotate the spine like this. So where is the left? This thumb will always point towards the left of the fetus. So this is the left side. And in the image, the stomach is on the top. That is the left. And even the heart is on the top. That is also on the left. So this is a normal situs. Normal situs. So another example, like again, this is a breech presentation. Breech presentation means I will put my hand down. Actually, we need to see only two. We need to know two things. We need to know the position of the head. Where is the position? Whether it's a cephalic presentation or a breech presentation, and we need to know the spine. Where is the position of the spine? So in this case, this which I am presenting now, it is a breech presentation. So breech presentation. So breech presentation, the hand will be down like this. It is down like this. So now imagine the mother is sitting next on the couch on the right side. So This is the breech, this is the head, this is the spine, this is the left side of the fetus. Okay, now again I see the screen. This is the probe marker. This is a probe marker, and the spine is over here. So I turn my spine towards the maternal right.
Excuse me.
Yes, please.
The fist represent the fetal head or fetal?
Sir, actually, this knuckles will represent the head. Knuckles.
Knuckles
will represent the head, sir. Yes, sir.
Represent the head.
Yeah.
Okay.
Knuckles will represent the head, and this will be back, spine.
Spine. Dorsum of the hand.
Yeah. So
I believe there is a pictorial representation also. There are some Suchita slide you can show. There is a this one you can see now. Himanshu babu eta dekhile dekhontu eta ei diagram
head is towards the fist.
Yeah. So it needs little bit of practice to understand, sir, actually. It needs a little bit practice. So if this is a breech presentation, if I take this, if this is a breech presentation, then the pointer is to, this is a maternal right. The pointer is towards maternal right. And here the spine is also towards maternal right. So I turn my spine towards maternal right side. Actually, my camera is ulta actually. So that is why a little bit confusion is there. So my spine is towards maternal right side. Actually, my camera is ulta. We can imagine it vice versa. Spine is towards maternal right. So if it is maternal right, this is the left. So this lower part should be the left of the fetus. We have to establish the left side of the fetus. But what do I find? I don't find the stomach here. I find the heart here, but I don't find the stomach here. Instead, the stomach is on the top. So it is a case of situs inversa. The stomach is on the opposite side with levocardia. The heart is on the same side, on the left side, but the stomach is on the opposite side. I just want to tell that first we have to establish the laterality, which is the left, which is the right side of the fetus, and then look for the stomach. It is not vice versa. Like what happens many a times, we look at the stomach and say, no, this is the left. That is wrong. First, we have to say which is the left of the fetus and then see where is the stomach. So the right hand thumb rule, with little bit of practice, it can be done. Actually, my camera is ulta, so maybe a bit confusion is there. Should I repeat once again, sir?
I think the best way is to imagine oneself, in the mother's abdomen, like if I am resting like this, what will be my left? What is my, that to me, it seems very, very, this is easy. This is also easy, but yeah, but then imagining oneself in the mother's womb is more, it gives more clarity. Anyhow, this is one way. There are different ways. It depends on what is convenient to you, but whatever you do, you must establish the situs right, 100% right. That's the thing. Go ahead.
Should I go to next slide, sir?
Yeah. Himanshu Babu, this situs is coming, we are coming back to it again because during the session of cardiac session, Dr. Preeti Dubey will touch this situs again.
Thank you, sir.
He will come back. Yeah. Thank you. Suchita, you can move ahead.
Yes, sir. The next important structure, that is the stomach. So if I am not able to see the stomach, the most in presence of normal amniotic fluid volume, most likely in maximum cases, it is a transient emptying. So transient emptying is not clinically significant. The baby must have just emptied the stomach. We'll wait for 30 to 60 minutes and again the stomach will get filled up. But while you wait, look around, you see the stomach may appear or be found elsewhere. That means if we don't find the stomach, our next step should be search for the stomach. Where is it? Is it lying in the thorax? The first place where we should see is it lying in the thorax. So we can easily rule out CDH, the congenital diaphragmatic hernia. So in case if it is not lying anywhere and you're not able to see the stomach, wait for 30 to 40 minutes. Again, if you see the stomach, well and good. If you don't see the stomach, again wait for the other 40 minutes to 1 hour. Then if you don't see, then it's better again to call the patient the next day. It's a problem, but we need to call the patient again next day. So I'll just give an example. About this case. A patient had come long back. The patient had come to us at 32 weeks. The stomach was not visualized. At that time, we did not search for the stomach actually. We just waited. We thought it is a transient emptying. And we told the patient to wait. We saw her for 2 hours, but I could not find the stomach. Later on, it was found that we had sent her to a radiologist. And then the stomach was found near the heart, and it was a case of CDH. We also went back to her previous ultrasound reports because she had done all the scans, the NT scan also, her TIFA scan also. I saw all the images, but none of the images the stomach was seen. In all the images, only this measurement was there. Only this measurement was there, but the stomach bubble was not visualized in any of the images. That means this could have well been diagnosed at least at the time of TIFA scan. So here lies the importance of seeing the stomach at all the scans. So now come to abnormal fluid collections. So there may be a difference in the amniotic fluid volume. There may be certain intra-abdominal fluid collections that may be an enlarged stomach. Like we see, this is an enlarged stomach here. So it may be enlarged stomach, may be due to pyloric stenosis. It may be due to duodenal atresia. Then you may find many cysts in the abdomen. Like cyst itself is so vast, it needs a separate class for discussing the abdominal cysts, because there are many cysts, and the most easy way to diagnose a cyst is seeing the position where the cyst lies. Then we can classify somewhat, we can give a classification of what kind of cyst it is. So just to recapitulate the situs in this patient, you see there are basically two anechoic structures in the abdomen. One is the stomach and one is the urinary bladder. Two bigger structures, and other smaller structures are the umbilical vein and the gallbladder, which we don't consider it as, we consider it as a smaller structure. Any other anechoic structure apart from the stomach and urinary bladder, it needs referral. It needs further referral. It needs further investigation. So in this case, it is a cephalic presentation. Again, we have to see two things. We need to see the position of the fetus. It is a cephalic presentation, and there is a spine. So what happens? Cephalic presentation means this way. This should be my hand. Cephalic here. Spine is down. Spine is down means my hand will go like this. My hand will go like this. And this is where, actually my screen is opposite. Actually, my camera is opposite. So it's going towards opposite direction. So this is my left side. So here in the screen, you see, this is the stomach bubble. The stomach is on the left. So here, this is the stomach and this is a cyst. So even in case of abdominal cyst, we have to establish the situs. Establishing the situs is the first and foremost thing when we start an examination. So this is a case of choledochal cyst. Then this is another cyst in the pelvis, which is next to the next lower down on the lateral wall of the pelvis. This is most likely an ovarian cyst because it's a female baby. There comes to dilated bowel loops. Many dilated bowel loops may be seen, and ascites. When ascites is there, you have to look out other fluid collections are there. There's a pericardial effusion is there or not, pleural effusion is there or not. Hydrox features we have to rule out. Then polyhydramnios along with GI obstruction. It may be a diaphragmatic hernia. It may be an esophageal atresia. Whether the stomach bubble is absent or persistently small stomach bubble. There may be small bowel obstruction in case of pyloric stenosis, duodenal atresia, jejunal atresia. So now come to esophageal atresia. So esophageal atresia, it is around 1 in 3,500 live births. It has a low prenatal detection rate. The two things which we have to remember in esophageal atresia. One is the polyhydramnios, and one is again the absent or small stomach. So if you don't find the stomach in the thorax and there is a persistently absent or small stomach in the presence of polyhydramnios, then we should think in line of esophageal atresia. So two things, again I repeat, it's absent or a small stomach. You don't find the stomach even after repeated examinations. I don't see a good stomach bubble. In addition to a polyhydramnios, which usually comes after 24 weeks. So in that case, esophageal atresia has to be kept in the mind. So the stomach bubble may be either absent or it may be a small stomach bubble. So if it is a atresia, then how come we get a stomach? We will not get a stomach now. But there are 5 types of esophageal atresia. There's a type A, B, C, D, E. In type A and B, this is a complete esophageal atresia. So in this case, you will get a totally absent stomach bubble. But in type C, D, and E, there is a connection. There's a tracheoesophageal fistula. So whatever fluid comes to the trachea, it goes to the stomach. So we see a small stomach bubble in this case. And the type C is the most common one. 85% cases are type C ones. That is associated with a tracheoesophageal fistula. Even type D and E also, you'll get a small stomach bubble. So comparatively, they are less. So when there is a strong suspicion and of esophageal atresia and the baby has already gone up to 30 to 34 weeks and a strong suspicion, then just after delivery, just postnatally, just after delivery, before starting the first feed, and X-ray should be done so as to rule out so many things. So before feeding, we can actually save lives.
Yeah, Dr. Suchita, please describe that ultrasound features of fistula. Previous slide, yeah, this pouch sign. Please explain. Yeah.
So actually, then we have to explain about the 4 lines of esophageal. Sir, I didn't bring that slide, sir. I thought it would be a detailed examination. So this one, sir. So actually, there are 4 lines. When we look at the sagittal section of the spine, then we can look at the 4 lines which denotes the esophagus. So when there is a atresia, then you can find a pharyngeal pouch over here. So that's all. I haven't prepared much, sir, about this.
Yeah, you are pointing to the trachea, right?
Yeah.
And
yes,
then
yes,
the
yes,
lower down, that is the esophagus. The lower down is the esophagus, and the fluid gets collection there, and it forms a pouch-like thing actually. Yeah.
Now come to double duodenal atresia. We all have learned in a PG time. There is a PG favorite question is a double bubble appearance. Where do we find? We find it in a duodenal atresia. So duodenal atresia is the most common perinatal cause of intestinal obstruction that occurs in 1 in 10,000 live births. So it is associated with trisomy 21 in 20 to 40% of cases. What do we see? We see an enlarged stomach and a duodenal cap. And this is also seen in more than 24 weeks. We see an enlarged stomach and a duodenal cap, and is associated with polyhydramnios in more than 24 weeks in 50% of cases. So I have done a good TIFA scan. At that time, everything was fine. The patient comes to me at growth scan. I see a double bubble. So it does not mean that I haven't done a good TIFA scan. It's just because of the late appearance, as Khurana sir has already highlighted about this late appearance of atresias. So this duodenal atresia also presents at the time of growth scan. The most common is it starts after 24 weeks. Polyhydramnios also comes after 24 weeks, and the double bubble appearance also comes after 24 weeks. So why is this double bubble appearance? The double bubble because the second part of duodenal is not canalized. So the upper part, the stomach and the first part of duodenum gets dilated. So it's not that you get a 2 double bubble. You may get a two separate structure, but you have to establish the continuity. Double bubble means the continuity between stomach and duodenum has to be established. This line has to be seen in case of duodenal atresia. So there is increased perinatal morbidity and mortality. And whenever duodenal atresia is there, there is very high, like 20 to 40% chance of trisomy 21. So what are the differences between small and large bowel? This is a small bowel. This is a large bowel. Small bowel is typically seen in the center of the abdomen. It also shows active peristalsis. And what about large bowel? Large bowel is seen in the periphery of the abdomen. It is seen in the periphery abdomen. They are relatively hypoechoic structures and they don't show peristalsis. So what are the upper limits of the dilatation of small and large bowel? According to ESOG, the small bowel, the upper limit is 6 mm, but according to FMF, it is 7 mm. And the upper limit of dilatation of colon is 20 millimeter. So this is how you classify in case of jejunal and ileal atresia. So about hyperechoic bowel loops. So what is this hyperechoic bowel loops? When you see the pelvis, you find certain hyperechoic structure. Hyper is more whiter. So the most common is a idiopathic. It is the most normal variant.
Please unmute. Please unmute all other participants except Dr. Boblina Mahanti. Please unmute. Right, Suchita, go ahead.
So the most common is idiopathic. It is absolutely a normal variant, but it may be associated with trisomy 21. It is also associated with various infections like CMV, parvovirus, toxoplasmosis, and it is also associated in future subsequent scans. You will find meconium peritonitis also. In that case, it may be associated with cystic fibrosis, the diagnosis of which is quite difficult in our settings like. So in high resolution machines, you may find many structures as hypoechoic. But what is the best way to diagnose this HEB? You turn the gain down, when you find the structure as bright as bone. Like this is a bone and this is the bowel. So the echogenicity of both the two should be similar. If the bowel should be as much echogenic as a bone. Then you say that this is a hyperechogenic bowel. It should be as bright as bone. Now come to abdominal cyst. The abdominal cyst, there are many, every organ may present as a cyst. So key to diagnosis, origin of the cyst. You have to see the location of the cyst. Where is the cyst located? If the cyst is located here in the upper abdomen, like so, it is near the liver, then you think of a choledochal cyst. If it is in the lower abdomen, if it is in mid abdomen, then we can look at that is intestinal duplication cyst. It may be a mesenteric cyst. It may be a renal cyst. It may be biliary cyst or any other organ. So whenever any cystic structure is there, there should be a prompt referral to the cystic structure. Like. So here, this case is a case of a choledochal cyst. Now come to abdominal wall defects. That is a quite easy diagnosis like omphalocele. So what happens in case of omphalocele? If there's an abnormal cord insertion, the cord inserts into the apex of the defect. This is the cord. This is inserting in the apex of the defect. It contains liver and the bowel, and you find a membrane covering. This is a membrane. This is a membrane covering. The prenatal detection rate is as high as 80%, and this is associated with abnormal karyotype in 50% of cases. That is a trisomy 18. So omphalocele is the one which is associated with abnormal karyotype, that is a trisomy 18. So the patient comes to me at 11 weeks and I find this. So should I tell it as omphalocele because its presentation is almost like an omphalocele? The patient comes at 11 weeks. No, I will tell the patient to again come back after 1 week or 10 days because this may be a physiological herniation of the midgut.
Better ରହିବ ସେମାନେ contact କରି न करी आपण तांको direct contact करी कि तांको through रे जाऊ. अच्छा speaker केमती share.
This may be a physiological herniation of the midgut and a spontaneous resolution may
specialist अछंती.
Spontaneous resolution may occur.
Hospital manager को number नियंदु तांको तो
yeah, participants, please mute yourself except the speaker. DHH Katak is, I think there is a lot of
So this is the fetus of 11 weeks. Fetus, and this is what I find. I find a structure like an omphalocele. Should I classify it as an omphalocele? No. I will wait for another 1 week or so, 1 week or 10 days. Again, call the patient and see whether this is there or not. This is continued or not. Because at less than 11 weeks, less than 12 weeks, there's a physiological herniation of the midgut. At almost all cases, there is spontaneous resolution has occurred. So do not push the panic button when you see this in the 11-week scan. So this is a postnatal picture of a baby with a huge omphalocele. We see there is a membrane intact. You see the membrane is intact. The cord is inserted into the apex of the defect. If you see carefully, there is a cleft palate also of the baby. There's a cleft palate. So as this is associated with trisomy 18 and cleft palate is also there, there's a very high likelihood of the baby having trisomy 18 or any abnormal karyotype. So this image I have taken from the Fetal Medicine Foundation website. This is a 11-week scan. So now let's come to another abdominal wall defect, gastroparesis. Gastroparesis occurs like it's 1 to 6 per 10,000 live births. It occurs more common in young mothers. This is associated with normal karyotype as compared to omphalocele, which is associated with trisomy 18. This is associated with a normal karyotype. Majority are isolated. It may be associated with oligohydramnios, and in 10 to 15% cases, late IUFD occurs. The chord insertion is normal in this case. The defect is below or to the right of chord insertion. It does not occur on the defect. It is either paraumbilical. It is either to the right or below. This contains bowel only as compared to omphalocele, which contains liver and bowel only. You will find free floating. The bowels are free floating, which is popularly known as a cluster of grapes appearance. This kind of appearance you will find in gastroparesis. So if you put color over here, we see the chord insertion is normal. It is next to the defect. This is a defect and this is the normal chord insertion. So another video which I have taken from the Fetal Medicine Foundation website. So there's a cluster of grapes appearance or the cauliflower appearance, which is popularly known as a cauliflower appearance.
It has no membrane over it. Huh?
No membrane over it. Yes. So again, the difference, I'll just recapitulate the difference. In case of omphalocele, the defect is in the midline at the level of umbilicus, whereas in gastroparesis, it is in the right paraumbilical. The covering membrane is present in case of omphalocele. It's absent here. It contains bowel and liver. It contains only bowel. The margins are well-defined, smooth margins. It is irregular cauliflower-like. The chord insertion is over the apex of the omphalocele, as we saw in the baby's image, and it is left of the defect. The chromosomal anomalies are very common in case of omphalocele and is very rare in case of gastroparesis. The prognosis depends upon the associated defects, where it is good in case of gastroparesis. Like another anomaly I would like to add, that is one is the body stalk anomaly. It's a very obvious diagnosis and it is a lethal anomaly, and it can be diagnosed as early as the first trimester. So what happens in body stalk anomaly? There's a presence of abdominal wall defect. There's a severe kyphoscoliosis. You'll find a short or absent umbilical cord. Typically, the liver is directly attached to the placenta without interposed umbilical cord, and it is very lethal condition. So this is another video from Fetal Medicine Foundation. So this is a liver, which is directly attached to the placenta. We can see the liver is directly attached to the placenta. There's a deformed spine also. Severe kyphoscoliosis, short absent umbilical cord, liver attached to the placenta.
Please mute, Dr. Niranjan, please mute. Yeah.
So what are the key points? Sliding from the chest to the abdomen. In the transverse view, document location of the fetal stomach. I repeat, fetal stomach has to be seen, and it's not just a small stomach. I need to see a good stomach. I should not leave the patient unless and until I see a good stomach. Absence of abnormal fluid collection in the abdomen, both the kidneys, umbilical cord insertion into an intact abdominal wall. If the stomach is not seen or found to be small with normal amniotic fluid volume, most likely to be normal emptying, but wait for 30 minutes, look again. At times, even in 30 to 60 minutes, you don't find a small, you don't find a good bubble. It's better again wait. If the patient, if still we don't get, again call the patient the next day. Many a times, next day also we see a good stomach. Accurate measurement requires that the AC to be imaged in correct transverse plane with correct caliper placement. Prompt referral for detailed ultrasound should be initiated if the herniation of bowel occurs after 12 weeks of gestation and there is abnormal fluid collection such as dilated bowel loops or enteric cysta seen. I would just like tell you about dilated bowel loops. Like there's a case of jejunal ileal atresia. They all are third trimester diagnosis. This won't be found in case of a first trimester, second trimester. Thank you.
Thank you, Dr. Suchita, for such a vivid clarification, and you made the subject very interesting. And yeah, all your slides are excellent. And Ashok sir, are you there?
Yes, yes.
Sir, please go ahead.
I think we've had a very, very good exposition of what we need to see. This was actually a marvelous view of everything. Congratulations, Dr. Suchita. It's always a pleasure to listen to you, and you made algorithms also. So, but you are using his guidance very well. Excellent. Are we taking? Are we going to do the questions first? Or
Sir, your voice is not very clear. It is breaking actually.
Oh, my voice is breaking. I see. Now is that any better?
Yeah, now it is better. Now it is better.
Ah,
yes.
Okay. So I was inquiring whether we are taking the post poll first, or we are going to do the
Sir, we can go to the post poll now.
I think so. Yes.
And we would like to listen to you again.
Yeah, I'm here.
Okay, sir. Thank you.
Sir, can I ask one question?
Sure.
Sir, actually, I wanted to give emphasis on another point. So actually, I wanted Dr. Suchita to answer this question so that we can discuss on this point. Sir, in case of duodenal atresia, two bubbles we will see in hello? Can I?
Yes, Rama.
Yes, Dr. Suchita. So we in double bubble sign we see two bubbles in case of duodenal atresia. Again, in case of gastric duplication cyst hua ya fir stomach diverticulum, in that case also we will see two bubbles. So how to differentiate between?
In that case, we have to look at the cyst wall. The cyst wall thickness will be different in case of this duodenal atresia and the gastric duplication cyst. That wall thickness will differ. That the echogenicity will be different in that case. I think Ashok Khurana sir can answer this better, sir.
You know, I'm trying to log in from my laptop. I will try and answer this question in a few minutes once I have logged in from my laptop.
Okay, sir.
So, ma'am, what will be the difference in echogenicity in these two cases? Can you please?
The contour also will differ. I believe the contour also will differ because if you have seen a double bubble, it is very, very typical. And you will see a continuum between the stomach and the first part of duodenum also.
Sir, in case of diverticulum also, there will be continuation, sir.
Yeah, but the contour will be different. The shape will differ.
In case of,
Let us listen from Ashok sir, what he has to say. Let us listen to Ashok sir. Yeah.
Basically the situation that we are looking at is the relationship between a diverticulum and also the hyperperistalsis that we get to see. So when we're looking at a particular thing, then there won't be that continuity to and fro peristalsis that we would be seeing. And that then becomes important for us to note. So the diverticulum will just be sitting there without showing up separately. But when it comes to the double bubble, the classical one, we will actually be able to see the process going from one bubble to the other.
Thank you, sir. Thank you. Thank you. Thank you so much.
sir, if you don't mind, can I add little more, sir?
Yes, go ahead.
Sir, what point I use in case of sir, if I see the anatomy, the stomach is in the left side and sir, duodenum is more towards the right side in the anatomy. So in case of duodenal atresia, the second bubble will be crossing the midline and it will be more towards the right side. So that if I'm wrong, sir, please rectify. But in other two cases, the two bubbles will be in the left side only. In case of duodenal atresia, the stomach will be in left side and the second bubble will be in the right side, which is the duodenum, and we will see a continuity which is crossing the midline.
It doesn't always work out so simply when we are trying to trace these two areas. So when we try to trace the stomach as well as the duodenum, then sometimes it can be quite tricky to be able to figure out right and left in that same image. And common diagnosis first. Let us consider the athletic possibility first and the diverticulum much later.
Thank you, sir.
Thank you. So, sir, we are going ahead with the post poll now.
Yes, certainly.
Sambit Babu, can you relaunch the post poll now? Sambit Babu, can you hear me? He is not reachable on phone. So let us see, Miss Trisomy. Sambit Babu. he is disconnected or not possible. So I'm not able to connect with Dr. Sambit Jena. So what I would request all the participants to review your MCQs again and just write down on a piece of paper which one you want to change now. After listening to the clear talk of Dr. Suchita Agrawal, is there you want to change your opinion from the present one? Unfortunately, Dr. Sambit is not there to launch the post.
सर नमस्कार रितंजलि कहूची मु सरोज पाणिग्राही सर को फोन करछि से संबित को टिए मेसेज दे देबे पोस्ट पोल क्वेश्चन पे
करंतु आगे करंतु ठीक है
कर देछि सर
I am not able to catch him on phone also.
ओके हां सर आगे सर मु सरोज बाबू को कहि देछि से श्री संबित को कहि देबे आगे
ठीक है
सर नमस्कार
because Sambit is most of the time traveling, you know, he is a UNICEF person and has to go to different places, and many places he doesn't have good network, so that is his difficulty, and he has many things to do also. This is one part he is doing, only a small part, but he has many other responsibilities. So yeah, I think if we can get him.
सर जदी क्वेश्चन गुडा अछि हमें डिस्कशन करि दउथबा
Questions are there, but they are pre-poll questions now, and I would still request all the participants to look at the pre-poll once again and see whether you want to change your opinion now. बोलिए
Should I share the slides, question slides?
हां मैडम अछि जदी शेयर कर दियंतु
Okay, okay.
Hello, Asmukul sir. Hello.
सरोज कोन
डॉक्टर संबित से ये हमारा विजिट कर टूर रे अछंती ता नेटवर्क नै सर आपण अछन सर पोस्ट अछंती आपण सर लॉन्च कर देले हो सर पोस्ट.
Oh, but I don't have those post polls. I don't have those because he has prepared na.
पोल टा को सर देबे बदे क्लिक कले हे जिवो सर.
Polls टा को
स्टार्ट पोल जो लिखाई थिबो सर.
हां सेटा मु करिछि. Polls टा I have done it polls, yes. Everybody can click the polls and they can see. Can the participants tell me by unmuting yourself that you are able to see the polls again?
We're only able to see the pre presentation.
Pre only because you know post poll the Dr. Sambit is actually he is traveling and he doesn't have network with in that area.
I think we'll take questions then, perhaps. Yeah.
So what we do is now I think let me analyze, sir. Can I go ahead and analyze all that?
Please, definitely.
Okay. So let us do the first question is omphalocele is associated with. So we all know that omphalocele is associated with trisomy 18. And whenever we see one anomaly, it is our duty to look for more, because trisomy 18 and 13, these are they have extra chromosomes and they will always have multiple anomalies. Say, for example, in trisomy 18, there will be clenched fist, club feet. Second trimester already the growth retardation is very, very prominent in trisomy 18. There is spina bifida, there is congenital defect of the heart, or CDH, the diaphragmatic defect could be there. There could be even tracheoesophageal fistula also can be there. So multiple. So my point is, the rocker bottom feet, these are the, and whenever we see a fetus in this, if the fetus is not flexing the hand, it is always like this, then suspect that it is a likely candidate for trisomy 18. So these are the things. So trisomy 18 is the right answer where we see an omphalocele. So the second question
So
is
B is correct.
again.
Sir, B is correct.
B is correct. Trisomy 18 is correct. Trisomy 18 is correct. Yeah.
Yes, sir. Correct.
So what is true about association of esophageal aphasia? So we already discussed about esophageal aphasia. Dr. Ashok Khurana had very elaborately talked on this subject. Today also, Dr. Suchita has shown us various types. Type C is common in 85% of the cases. You will see either we will see a small stomach, or there will not be any stomach. There will be polyhydramnios after 24 weeks, he has shown. And it has a very, very low detection rate. This also Dr. Khurana had talked last time. The detection rate is only 24 to 32%. So all of the above, these all of the above
Is that
are
correct?
correct
Yes.
answers. All of the above are correct answers. Now, the double bubble appearance is seen in, so the double bubble appearance is seen in duodenal atresia. So already Dr. Suchita told that the second part of the duodenum is atretic. The first part becomes the dilated bubble. So the first part is the second bubble we see beside stomach. And again, duodenal atresia is very, very common in trisomy 21. So this is also a feature to remember, that double bubble in trisomy 21 and omphalocele in trisomy 18. So
18.
yeah. Question number 4. All are true about transverse section of the abdomen except, again, there was a very beautiful slide. The landmarks were very clearly delineated by Dr. Suchita Agrawal. That stomach bubble has to be on the left side. The umbilical vein has to be present in a very short, it doesn't have to be a very long segment. So, and also it should not be at the level of the chord insertion, and there has to be single ribs on either side. And both the here in the question D, the kidney should not be there in that plane. In AC plane, if you are measuring abdominal circumference and if you are looking even at the upper pole of the kidney, then you are not at a correct plane. So kidney is not a part, that's not a landmark. So D is the wrong answer. I mean, kidney should not be there, except. So exception is the kidney. Number 5, the most common cause of non-visualization of fetal stomach in the presence of normal amniotic fluid. So always this is to be seen, because if there is a fluid, the fetus is likely, definitely it will swallow. If everything is normal, if the fetus is normal, it will definitely swallow amniotic fluid. And transient filling, transient emptying means, say the fetus has emptied the stomach. So that is the commonest thing we find. So what we do, say in my setup, what I do is, if I am not able to see the stomach, I go on examining the rest of the anatomy and spend, say, some 10, 15, 20 minutes, and then come back to stomach once more. Even if it is not, I still call the patient again. Or after, say, 30 or to 60 minutes, we should look at it again. So transient stomach emptying is the commonest cause, because we don't suspect, we know that anomalies are not that common. We see in 3 to 5% only. So rest of the time the babies are normal. Therefore, we first think of normality, wait, and then if it is not there, we think of abnormal situation. So transient stomach emptying is the most common cause of non-visualization of fetal stomach. Now, question number 6. Following are true about hyperechogenic bowel. So the alternatives can be a normal variant, can be associated with trisomy 21 and fetal infection, can be associated with meconium peritonitis, or all of the above, D. So the right answer is all of the above, because the slide, there was a slide also, it had, Dr. Suchita has already shown us that it could be a normal variant, and it has to be as bright as a bone. So you decrease the gain or take out the harmonic imaging, remove harmonic imaging and look at it. Possibly you will come to the correct visualization. And I think all of the D is the right answer for question number 6. Question number 7. All the following are true about gastroschisis except the alternatives are defect is below or to the right of chord insertion. This is the right one, associated with trisomy 18, cluster of grape appearance, and free floating bowel. So again, gastroschisis is very rare. It doesn't have any genetic basis actually, because it is a developmental defect. When there is a closure of anterior abdominal wall, it doesn't close properly, and therefore it is an abdominal wall defect. It is, the chord insertion will be normal in cases of gastroschisis, whereas in cases of omphalocele, what happens is the gut, which is herniating normally, the physiological process, the gut is not able to return back. It doesn't come back. And therefore, when it stays, it is abnormal. Normally, in physiologically, it should be coming back intra-abdominally. It should be back. So B, it is not associated, it cannot be associated with trisomies. So that is the wrong answer. So B is the correct answer. Exception is the B.
Yes, sir.
Yeah. Now, question number 8. All the following are true about omphalocele except. Again, there was a beautiful slide which Dr. Suchita has shown. Chord inserts on the apex of the defect. Second point is contains liver and bowel. Membrane is intact. And the alternative D is can be detected as early as 10 weeks. No, it cannot be detected. On the contrary, we wait and go beyond 12 weeks, because up to 10 weeks, it is a physiological. There was a very video shown by Dr. Suchita where she showed a slide from Fetal Medicine Foundation, which is very clear, and therefore D is the right answer, because at 10 weeks, it is a physiological process, and it is not an abnormality. Question number 9. Following are true about abdominal cysts. Now, again, we know that in the whole of abdomen, we have multiple organs, so many organs, and cysts can emerge from any of them. It could be from liver, it could be from gallbladder, it could be from liver, it could be from bowel, it could be from the mesentery, it could be from the genetic organs, like if it is a female fetus, we suspect ovarian cyst, and the level and the origin. These are then also what happens is these can also disappear in course of time, or it could be emerge bigger than what it was. So follow-up is one thing. And again, these are, your diagnosis can always change, because as the fetus is growing, the location of the cyst may also change. Therefore, all the above, the alternative D is the right one. Renal tract anomalies and dilate, all it can be, abdominal cyst can emerge from any abdominal organ. So all of the above is the right answer. Question number 10. Following are true about small bowel obstruction. Multiple fluid-filled loops of bowel more than 7 mm in diameter. It presents later than 25 weeks of gestation. The other alternative is can be associated with polyhydramnios, and the next alternative is all the above. So all the above is the right answer, because we know that whenever there is a bowel obstruction, the fetus, whatever it will not swallow much more. The fluid will accumulate in the abdomen and surrounding the fetus, causing polyhydramnios, because any mechanism which impairs the fetal swallowing mechanism will cause polyhydramnios. And the bowel loop, as also described, the normality, Dr. Suchita had shown us that 6 mm is the cutoff limit. So more than 7 is definitely abnormal, and it will always be associated with polyhydramnios. So all the above, D is the right answer. And I believe this is the end of the poll, and all of my friends must have cleared their doubts after the vivid, such a clear message or presentation from Dr. Suchita. She has done her slides excellently, and the questions are, you should be able to hit 100% right. So thank you again. And I think Dr. Ashok Khurana sir, can you say something about the whole? Ashok sir, are you there? So I think he must also, his connectivity was also very, sir, there.
Yes, I'm back on the good connectivity. Yeah, it's been a tricky day with connectivity, but I think we've had an excellent session, and we will run the post poll sometime. But I think we had some very good responses on the pre-poll, which is very, very encouraging. And that was nice. And we've had an excellent presentation by Dr. Suchita. It was absolutely marvelous to revise all these concepts with her. And we do realize that we are always constantly learning. And these pearls of wisdom, such as the common associations, such as the findings that will help us to look further by simple diagnosis, and a diagnosis even before we actually do genetic testing, is something that we have to realize we can do to a large extent. And there were some mentions on what are the associated abnormalities. Those also take a great importance. Sometimes we do understand that you might have a small ventricular septal defect, but if you have a small ventricular septal defect, but you have a large, if you have like a duodenal atresia, then obviously the concept changes. And therefore, when we find one anomaly anywhere, we must look elsewhere. And it's not infrequent that the anomaly that we find within the abdomen will actually determine the actual prognosis of a smaller anomaly you find elsewhere. So if I were to find a mild pelvic ectasis, but I find a jejunal atresia, then obviously the jejunal atresia will take precedence over determining what is going on. So I really must be able to look at the entire checklist. That checklist is very, very important. And you heard that right in the beginning, you heard from Dr. Hasmukhlal that he first looks for the stomach. If he doesn't see it, then he goes on to finish the survey, but comes back right again to see it again. So gastric filling and gastric emptying are both very important components of the evaluation. And for the anterior abdominal wall, it is important right in the beginning of your evaluation, when you're evaluating the stomach, the abdomen, to actually look at the level of insertion of the umbilical cord. And that will give you the clue immediately to the diagnosis without even needing to think. All these points have been really highlighted beautifully. And I know that a lot of you are now using the PowerPoints on a regular basis. And it is good that we will be able to share the PowerPoint again. We're not able to always share the videos, but we will be able to share the PowerPoint. And we are always available for you for questions. Even if you have a question pending from any of our previous sessions, you can ask it in our next session. So Friday before and after is always open house, as I call it. You can ask whichever questions you want. But today has indeed been a very fulfilling session, and I look forward to the next session already.
Yes, the next session is, sir, about obtaining cardiac views by Dr. Preeti Dubey.
Yes.
It's a lengthy one, but and she's a fetal echo is her favorite subject.
Yes.
So please do again. We will need your presence again, and so
I look forward to that. Always look forward. This is a marvelous program. Yeah.
Thank you, sir. Thank you so much.
Thank you. Thank you very much. And goodbye.
So next, all my participant friends, it is very enjoyable session today, and hope that you have it has served some purpose for you in shape of learning. And from Monday morning, you will be probably be able to do a better ultrasound, And the next session is about cardiac views by Dr. Preeti Dubey, and we all know that cardiac defects are very common, and therefore this is one of the important issues that we face, important challenges also, because heart is such a small organ, and also we have to look at the heart from different views, and all the views will be defined by Dr. Preeti Dubey, and she's an expert on fetal echo, and she'll be presenting it very vividly and in very understandable manner. So please join us again, and we look forward to any of your doubts. You could always email, and I believe most of my participants friends have our email. So again, I am putting it in case you have some questions. We have got an expert panel also. We will be sharing it in the virtual. I think all of you are members in the virtual WhatsApp group. So we will share our email in that group. Dr. Suchita, Dr. Rama Manjari, myself, Dr. Preeti Dubey, all the names we are going to put, who are all our trainers. Samarendra is here. So you could ask if you are not able to clarify in this virtual program, you can email us so that we will help you in answering all your doubts. So thank you again. And Dr. Sambit is not there. Saroj Babu Achanti? Saroj Babu Achanti? So I think now we are on the point of concluding this meeting. It was a great pleasure to see you all. So I think we can leave now and just work our evening program. Either some of you must be having some patients in the clinic or some other work. Please, you can go ahead and come back next week. So we meet again. Thank you so much. Thank you, Dr. Suchita. Wonderful presentation. We all enjoyed. I have a friend here, Dr. Balram Sahu is there. He is from my place, Dr. Balram Sahu. He is from Titlagarh. Balram Sahu Achanti. Dr. Balram Sahu, are you listening? Shravan Sahukar is from Raigada. Rama, you are going to Raigada. Dr. Shravan Sahukar is from Raigada.
Yes, sir.
Yeah. So I think we are ending the meeting now.
Thank you, sir. Thank you so much.
Thank you. Thank you. Thank you.
Thank you, sir.
Thank you. Yeah.